or good afternoon if you're watching us on tape delay. If you've got your DVR set for Coffee Compliance and the Chuckleheads, you're catching us on the broadcast. But if you're live, good evening. Or I guess if you're on the West Coast, good late afternoon. But we're here live. Eric Rubenstein, here with Sean Weiss, here with Jordan Johnson, fellow Chuckleheads. We got a packed house tonight. We got a lot of things to talk about. I've been talking to both Sean and Jordan offline. I'm going to put a little bit of extra light on. Look at that. And we're on fire today. It's just unbelievable. The amount of stuff that we've got to talk about today is it's pretty fast and furious. There's a lot of stuff that's going on, both in the enforcement community with some settlements. The strict liability issues continue to be there. Still tons of stuff out there on private equity, mergers, acquisitions, and the like. Before we do that, I want to say good evening to my two partners in crime. I'm going to see Jordan in a couple of weeks. Going to be out at a conference out in New Orleans. Be seeing my man Jordan for that one in a few weeks. It'll be good to see you in person.
I was asked not to show up to that one.
Well, you're a troublemaker, so I can understand.
I was excluded.
I mean, can they really? I mean, do they really want all three of us? That's the problem. It's like a dose of medicine. Only two of the three at any one given time. I think it's probably safer.
You know what I say? Addition by subtraction.
I love it. I love it.
You know, let's get right into it, because this is something that's out there, and before we get to some of the other stuff that we want to talk about on some economic related healthcare kind of theories and news, let's talk for a minute, Jordan. I want to start with you. There's another big private equity / healthcare thing going on. If you've been following this, Bright Healthcare raised up over $1 billion, I believe, in the past year. And after talking about that they didn't need another round of funding, they're now talking about the prospect that they are not going to remain sustainable with what they've currently got. Let's talk about that a little bit. I mean, it's another one. It's not a health IT, it's a payer. There's covered lives. Let's talk about sort of like, where could they have gone wrong? But I think the bigger question is, what happens to them as a plan? Like when a plan is financially insolvent, what happens on the payer side? What happens on the patient side on this? Jordan, what do you think?
Man, I mean, this is that frustration point we've talked about, but we've seen it on the private business side of PEVC. But now when it happens to the payer, to your point, now it's a heightened sense. Now we have potential patients that have bought in, they're being covered. What happens when this company loses solvency? And by the way, when you throw the red flag to say we think we may not make it, that's a good indicator of we've pulled the lever. We're not going to make it. And so at that point, I wouldn't say they try to soften the blow, but with patients and care at stake, it's how do they transfer that? How do they transfer the coverage? And unfortunately, I think this is fixing to be a trend. If you guys are watching, there is a ton of business right now of PEVC in the space of we're going to work with you, the employer, to save patients money and save you, the employer, money. And this like opportunistic business has really just popped up. And it reminds me of this the Bright Healthcare and the payer deal. Is all of a sudden we haven't seen this before, but I think people are looking for that quick, easy niche market. And it's like, guys, this wasn't rocket science, but what scares me in the Bright Healthcare deal is the sheer amount of money that was raised to then say, we don't have it figured out. I don't think it was a money issue, okay? I don't think it was a money issue. I think it was an operational issue of really understanding how it worked. And when patients are at stake, as far as coverage goes, we've talked about that we think there needs to be some form of sanction in just the regular business arena. But now, are the stakes higher that there should be some level of added accountability for the people that do this, because these patients are going to be displaced, their care could be displaced. And I think it's a tough judgment call, but it wasn't a money issue. It was they didn't know what they were doing issue and didn't have the right people at the table.
Yeah, one of the things that's interesting is, kind of parlay to that is I think there was a lot of interest in seeing where things in healthcare were going to go. I just read something today that talked about telehealth visits have plummeted substantially, and people are going back to their doctors. And some of these IT or health IT, I think is what we're really calling them. Some of these health IT organizations that were looking to really invest in the telemedicine platform, their stocks are all taking a big hit. There's 2 or 3 out there today where there were some announcements made that the amount of money, the stock and valuations have really dropped as a result of some of these organizations that were really focused on the telemedicine, sort of carrot and stick, right? That this was really going to be the move forward. Now, obviously, there's always the pluses and the minuses of talking about COVID. When we're talking about the plus of COVID, I think the fact that CMS moved to create an environment to foster a positive group for role, I should say, for telehealth and telemedicine, right? I mean, before COVID, the availability of telehealth and telemedicine for the Medicare population was almost nothing. I mean, there was the originating site and the use of the GT modifier and metropolitan statistical areas and all of this stuff that was inordinately confusing. You really had to be living in some rural community where, there was only one doctor and, half the stuff would have to be done that way. So COVID created this great opportunity to allow for telehealth and telemedicine, which has also obviously created the great opportunities for telefraud. So, Sean, let's turn it over to you about how, I was surprised when I saw that there was this huge plummeting of people that were really going back to see their doctors in the office, and this is going to really bring us to the next piece that Jordan wants to talk about on our costs. But Sean, we talk about telefraud and telehealth and telemedicine and tele whatever constantly. I was shocked at this. I don't know, when I sent it over to you, what your thoughts were.
So it took me a few minutes to kind of digest this, right? Because if you think back during the middle of the pandemic, or even as we were starting to come towards the end of the pandemic, right, before this last extension to December, a lot of folks were talking about the fact that, look, we're going to continue to use telehealth services. We like the convenience. We like, the fact that when we have a dedicated appointment time that the doctor's going to be there. And I think, like with most things, and I hate to say that telemedicine was a fad, because I don't think that it really is. But I think in some respects, where seniors, especially seniors, want that face to face with their physician. One, a lot of seniors struggle with technology. And if these telehealth, and I'm talking telehealth in the true sense of clinical care, right? These are legitimate organizations that have legitimate physicians on HIPAA compliant platforms, having a face to face, just like we're doing right now, where they could observe a person from an objective standpoint. They can capture all the, subjective information that they need. I am not surprised at the decrease in the level of utilization of telehealth services, especially in the seniors, with our senior population, just given their technological difficulties and the fact that these folks want to feel that they want to have that face-to-face presence with their provider of care. That's, I'm old school. And I will tell you, for me, there's nothing that could replace, for me, that face-to-face visit with the physician, getting that handshake or that fist pump or whatever it is. And knowing, even if it's for just that 5 minutes, that provider was with me. We were having a genuine conversation, and I could feel that level of communication. Now, I don't mean to upset any of the telehealth companies, but the numbers don't lie, and there's a decrease in this. And I think if you
Uh,
go ahead,
Sean,
go ahead.
I think the other thing that we exploited was also that really got exploited during is the lack of broadband connectivity. I think a lot of people just think the internet, like we're on right now, streaming, like everybody has that, right? The numbers, as Sean's showing, have dropped significantly. The number of people that have access to broadband has dropped significantly. Also, remember a lot of the internet carriers provided subsidies, or you didn't have to pay for your internet bill, or they cut breaks. Well, all that's ended now. So now if you have it, those rates have gone back up. So if you didn't have it before, maybe you can get it, but now you're going to have to pay for it. So there's a lot of just on access to broadband internet to be able to facilitate some kind of telehealth. There's still an enormous gap that has to be filled. And I know, there's been a lot of thought, do we have like a
Absolutely.
I think that's a big part of it.
Yeah.
Eric,
No,
talk about those trends that you put up, buddy.
yeah. So I'm, while we're sitting here, I'm going through and I'm just looking at some stuff, and you can see here that the numbers. So, April of 2021 to the end of October 2021, it's a pretty substantial drop in the percentage, of people going for the visits. It's greater with children. The drop is much more dramatic with children, but it's a pretty dramatic drop for adults. And I think there's something absolutely to be said about what you said, Sean, about wanting to see the doctor. I think if we're talking about, so first of all, we've talked about this a million times, the technology piece of it, and I have said for many years that I think that the telemedicine technology of today will benefit the Medicare population of tomorrow. I use my parents as, maybe not right, but I use my parents as the barometer. My dad is 81, my mother's 77. They are not technologically advanced at all. My father has a very hard time, using technology. It's just not something he grew up using. They have a computer, they struggle with it. They have iPads, they struggle with sometimes using the iPad. They're getting better at it with constant use. But, in terms of using the technology, up until probably a month ago, my mom still had a flip phone. And even now, she's still got like a dumb version of a smartphone, where she's doing this to type.
Yeah, so you raise great points. So you and I are in the same boat, right? My mother is 81 years old. She has technology challenges. She has a computer. There's a lot of things like now, if you tell her to go on, if you tell her she can go to the online casinos, she has no problem finding those, right?
Absolutely.
She knows how to deposit money into her account, and she knows how to play those slot
I like
machines.
it.
But
There's
if
truth to that. But
yeah,
at the same time, when you go to FaceTime her, I FaceTime my parents, and it's a lot of this.
but here's the point that I was going to make, right? So she did a telehealth visit, right? So she's 81 years old, and I would say she is your prototypical Medicare patient. She has every ache and pain that is known to the human race. She uses Dr. Google to diagnose every symptom that she has, and it always turns out to be the worst case scenario of cancer of some sort. So during the pandemic, she didn't want to leave the house because, she was scared of contracting COVID. So when she had to have an appointment with one of her providers, she did the telehealth visit. And for some reason, she had no problem figuring it out. But as soon as they removed the mask mandates, she said, I want to go see my doctor. And I said, but you said you like the telehealth. And her response to me was, I know, but I go to Emory University and they're the best. And I want to see my doctor in person. So, now you tell her to use her phone, and she has like one of those, it's a smartphone, but it's only as smart as the person using it. And
Yeah.
I've put Uber on there, and I've tried to show, and now for me, I get at least 10 texts a day. Can you get me an Uber for tomorrow? I have an
Right.
appointment at the end of the week. Don't forget, when I'm there, you need to send an Uber to pick me up. Now, technology is great, but it's only great when it works. But, the last thing that I want to say, Eric, and I think this is the most salient point about private equity taking somewhat of the start to what I think is going to be a market correction on these investments to their portfolio of these telehealth companies. You and Colin Callahan and I had a conversation about this, and it comes down to not doing your pre-investment due diligence. Looking at what the trends were prior to the pandemic, understanding what the utilization of telehealth services were, to me, could have given a clear indication of, once we're out of this pandemic, what the actual real utilization of these services were going to be. That way, if you decided that you were going to add this as something into your portfolio of companies, you could have said, my strategy is going to be a short-term hold, because my short-term goal is 12 to 18 to maybe 24 months to maximize the revenues that we can, and then to sell it off to another group, or to dissolve it if everybody
Right.
has decided to go
Well,
back
that's
into.
well, that's a good point. And obviously, we're not here to have a conversation about finance
Right.
and stuff, but there is the big issue. I think really is that the pandemic and all things COVID created hysteria in a lot of different things, right? So forget, right, like, outside of the fact that nobody wants to work now, and the fact that supply chain is what it is, and the fact that people are applying for jobs that they aren't even looking at anymore, because there's a feeling like, well, because I have an opening and people know that I want to hire someone, I don't have any of the qualifications, but I'm still going to apply. Like, there's a lot of that mentality that's going on. But the issue is that when you're looking at a technology that evolved and really exploded as a result of an anomaly, right? A ripple in the universe. And that's, I think, part of what the issue is. And outside of fraud, waste, and abuse, where that's always going to be an issue. And I think that what's really going on in the world today, I really hate when people say 2022 is the year of the audit. I don't think that. I think that what happened was we had a very long period of time where there were no investigations, audits, recoveries, money wasn't being, recovered back into the programs. And now that uptick is going on and money is being recovered, and payers are now starting to say, hey, we need to keep this uptick going because there is all of this money out there that we really weren't recovering. But I think that when you look at the stuff involving the technology with respect to telehealth and telemedicine, the big difference to me is that these are sectors that were the result of an explosion due to the ripple in the universe. And now
Right.
that it's leveling off, people look, my parents, I'm sure your mom, they were tired of sitting in the house for 2 years. They got they got the opportunity to go out and get to their doctors and do whatever and feel like they needed that one-on-one interaction. And that clearly, is a factor that, that's come out. The downside to that, I think, is going to be that providers who had the opportunity to see a broader range of patients with a lower overhead. Hey, today is going to be, the office is closed today because we're doing just telehealth visits, right? So you're not paying for the air conditioning to be on. You're not paying for the lights to be on, right? Your staff are going to work from home. So, are they going to be more productive because they're working from home as well, or you're, reducing your staff, or, or doing whatever. And I think those are some of the collateral things that come about. But not to shift gears, but to stay in that same vein, Jordan, you were doing some research and found some average costs for some things, which I think parlays really importantly into the kinds of things that people are looking to get when it comes to getting these items, services, and procedures. There's another factor, which is, do I leave my house and drive in my car and have to pay for parking and pay for all of this stuff? So let's talk a little bit about that, Jordan. What some of those crazy numbers that you saw?
Yeah, so we got some numbers yesterday. So each month the government puts out, and the national, what rent costs, what mortgage cost, and so we had that number come out yesterday. And so the average, the national average, and I'm looking at this on my other screen, was $1,800 for rent for a single bedroom apartment. And so I started to kind of click around of different states. So they have a map and it's updated so you can actually see how much the prices have increased. So, like in the state of Illinois, it was, it's a $1,356, and a year ago it was 712. In North Carolina, 1474, and a year ago it was 936. And I'll do a couple more here, but New York, 2277, and a year ago it was 1700. California 2723, and then a year ago it was 2071. So not a huge difference. But like in Washington State, $2,100, and a year ago it was 1,500. So we start to do some of that math, and we start to figure out that, okay, so let's take the average is $1,800 times 12 months, that's 21,600. So then I looked up, what's the average salary been? And so, the highest salary I think was Maryland. And then, here in Mississippi, we always finish strong, guys. We are always number one for the wrong reasons. Usually that is illicit drug use, teen pregnancy, obesity, and now we get it for being the lowest salary in the country. So, it's never a dull moment here in Mississippi. But so it was like 44,000, and then Maryland was like 82 or something. Average them together, it ended up being like 69,192. So Sean brought up a good point. So you have an average salary of 69,192. We take 12 to 15,000 off the top of that, just for taxes. So now you're down to like 48,000 minus this $1,800 rent a month, which is 21,000. And then you start chopping off everything else, groceries. So you're left with like 10 grand, 15 grand. And so this big, in healthcare right now, we're seeing a lot of, well, why aren't patients getting their screenings done? Why aren't they getting their mammograms done? Why are they non-compliant with their medications? And I think these smokescreen words we've talked about, like social determinants of health. If I hear that one more time, it drives me nuts. Guys, there's only one social determinant of health. We've talked about it. It's income, period, end of story. You can list all the other ones, but income is always the most important. Maslow's hierarchy of needs will always prevail, and food safety and security will be the first. And that's what people are going to pay for. And what gets kicked to the curb is healthcare. And so I think this really brought things to perspective of what people are spending their money on, especially with inflation, $7, $8 a gallon for milk. The other thing, and I don't know if people realize this, but during the pandemic, the government spent $24 billion on school lunches for children. We had lots of argument up about this because as school just started back, they took that away for the free lunch program. And apparently there were still people having difficulties making ends meet. So at the end of the day, there's not much air left in the balloon after everything gets released for what they're spending, and healthcare is what's taking it, really taking the hit for people and to be able to seek that care. And so they're going to present with later stage disease, more complex comorbidities. It's going to cost more to take care of the patients. And that's why we're seeing this focus now of CMS and the government and a bunch of people. They're really trying to focus back to primary care, which we never should have got away from focusing on primary care. But it's not a luxury, and it's not, it doesn't make big money, but that's really where the focus should have stayed. And so we're trying to refocus that. But this is an absolute mess when it comes to, you can't convince people to spend money they don't have. And most people don't want to be a financial burden on their family. So they're going to take care of those basic needs first, and they're going to let healthcare slip. And so these numbers were just kind of staggering to me to see that that's what people are paying for rent. And it's a huge increase, almost a 22.6% increase across the board over the past 2 years.
So one thing that I'll say, Eric, and I think what it comes down to is people facing reality. Okay. We are living in a very different time right now for a lot of different reasons. And the majority of what we're experiencing is not good. But to Jordan's point, I understand this part wholeheartedly, where people are looking at screening and preventative services right now as sort of a secondary luxury that if I can avoid going to the doctor and running up a bill where I have to pay 20% of my copay, or I have to pay, like me, if I go to a specialist, it costs me $60. That's a chunky copay, man. So if I don't have to go to the doctor, I don't want to go. And if somebody says to me, well, your insurance covers you for an annual physical. Well, yeah, my annual physical may be covered, but I know I'm going to go see that doctor, and the doctor's going to say, well, Sean, you also have, you know, heart disease, or you have, whatever it may be. And, now it's, hey, we're going to put you on this new medication. Or now it's gone from just an annual physical that may have been covered by my insurance company to now I'm having to pay 20% of a 99213 or 99214. So I get it. And I'm not begrudging the physicians, but the fact of the matter is very simple. Stop watching mainstream media. I don't care if you're on the right side of the aisle or if you're on the left side of the aisle. You got to look at the reality of what's really going on. People are hurting. People are hurting significantly. And if you take a look, everybody's talking about, well, how did this whole food chain, how did this whole supply chain mess happen with baby formula and with medications and with parts and things? Because for 20 something years, our politicians, our elected officials kicked that can down the road for the next people to deal with. And guess what? There's only so far you could kick a can before you can't kick it any further, and the chickens come home to roost. And that's exactly what happened here. So to Jordan's point, at the end of the day, if you take somebody with a $60,000 to $70,000 salary and you take 45, if you take 60% of that away for direct costs, for fixed costs, rent, automobile payments, gasoline, the increase in food costs, because we have an inflationary rate for the month of July of 8.5% and 8.9% for the month of June before that, people are going to look at that and say, at the end of the day, I got nothing left. And you want me to spend it on going to the doctor? No, I want to be able to, take my spouse out for a meal, or I want to be able to go see a new movie, or I want to be able to do something to get my mind off the last miserable 2 years that I've been subjected to.
And that's what's made it hard for me, for a bunch of these companies that have come in the space, these startup companies that are like, hey, if you're an employer and you pay us, we'll help your patients navigate the system, but your employees navigate the system as patients when they become a patient. But like, the employee has to pay for that. That's more money out of their check to enroll into that. And what I don't understand is there's already a ton of free services out there that do that. So it almost seems opportunistic. And if they're banking on the patients to spend that extra money, it's not going to happen. I went to the pharmacy today, to Sean's point, filled a prescription. I asked the pharmacist, I said, what are your holds? Basically meaning, what's your percent increase, or what have you seen as far as patients that the doctor prescribes them something, you fill it, they show up and decide, I'm out. Like, I don't want it. I can't. And they said it's 50% greater than it was a year ago, that more and more patients, and we're not just talking about simple meds, we're talking about blood pressure meds, like really significant meds that patients are just simply electing to not take.
Yeah. So let's actually build on that, because this wasn't really one of the topics that we were going to talk about. Well, let's talk a little about that, which is that part of the new legislation that was passed includes the ability of CMS, or the Medicare program, to negotiate prices in Part D. So, when the Part D program was put into effect in 2006, the language really did not allow for negotiation of price. There was actually a very specific piece of language in the legislation. There was the non-interference clause, right? So essentially, the government put very little controls on what was going on with Part D drugs. There was a very little bit of it. I mean, it caused a lot of explosive costs with respect to the Medicare Part D program, because in no other sector, Indian Health Services, Bureau of Prisons, you name any federally funded program, they all have the ability to negotiate prices. Even within state laws and Medicaid, the states all have, there's all kinds of legislation written into state law with respect to pricing, whether it be using what they call the Red Book, or it used to be First Data Banks stuff, where you can, where you'd be entitled to rebates and all that. We're going to talk about rebates in a minute when I go on my tirade about Mellencrot. But the point is that you've got this as an actual issue. Now, with the new legislation, it's something, I think it's 50 or 60 drugs that will be allowed to be negotiated. The problem is that it's not all at once. It's 10 drugs one year, it's 25 another year, and it's a 4 or 5 year program, which makes like no sense whatsoever. But more importantly, the thing that nobody is really addressing is that within the next 5 years or so, the Medicare program, primarily Parts A and B, are going to start to become insolvent. Now, Part A is going to become insolvent before Part B, because Part A doesn't have the premium payment in, right? It's 100% through tax appropriations, whereas Part B's got the cost sharing and all of that stuff. So, and that's sort of the elephant in the room, Sean and Jordan, getting back to both of your points, is that we have kicked the can down the road, and what is it you said? The roosters are calling home, the chickens or whatever.
The chickens have come to roost. The chickens have come
whatever
home
it is
to
that they're
roost.
doing. At the end of the day, the problem is that we've got a situation where we've got a program that's going to be insolvent. Social Security is right behind it. That's going to go insolvent, where we're going to be spending more than we're taking in. In any other place in the world, if you spend more than if you're having to pay out more than you take in, that's called debt, right? We have it all the time, but we're not addressing that. And I think that's where some of these technology related platforms, and we'll go back and we'll talk about Mark Cuban, and we'll talk about things like GoodRx. My father, 81 years old, not technologically savvy at all. Yeah, he can't order an Uber. There's a lot of can you hear me, but he found GoodRx, and he's actually using GoodRx now. And this is amazing. Both of my parents, Medicare primary, they have a supplement. They pay thousands of dollars a year for their supplement because they have a bunch of comorbidities. So they're on all kinds of medications, no different than your mom, Sean. And my father is going to GoodRx, where he's not even using insurance that he's actually paying for, because at the end of the day, what he's paying for in cash is less than what his copay would be using insurance. So it's mind-boggling to me. And the fact that you've got these technology companies. So PillPack, which is now owned by Amazon, right?
Right.
They're getting into this. You got the Mark Cuban piece of the puzzle, GoodRx, things like that are the things that are kind of shifting the tide, and people are just saying, like, I'm mad as hell and I'm not going to take it anymore. But
Right.
We're not really addressing the fact that the Part D program's initial impetus of not being able to negotiate is something that was so askew of every other thing that was going on in the pharmacy healthcare world that was out there. So it's just kind of this amazing thing that's kind of going on.
No,
But
and
I
then
do want to, and unless you guys have something you want to add to that, I know like we talk a lot about it, so I want to just pause for a minute.
Well, I had one point to make, but go ahead, Jordan, first.
No, I was going to say, and then in the midst of this, we know that the programs are going to be insolvent, but they want to lower that age from 65 to 60 for Medicare, which basically speeds that up. Again, I know that's one of the initiatives. We're not here to talk about politics, but if it's going to be insolvent, probably not a good road to go down. So go ahead.
I think one of the telling tales is, if you take a look at what CMS is proposing to do, is that by 2030, they want all Medicare Part B patients to be enrolled in an ACO.
Yep.
They want all to be enrolled in an ACO. And it goes back to your point, Eric, which is they want the gatekeeper. We're seeing more of the patients being pushed towards these Medicare Part C plans, these Advantage plans, because it's cheaper for Medicare right? Because these HMOs, these Part C programs will pay providers at 70% of the Medicare rate.
Right.
So it leaves more money back in the system. But the big problem that you're going to run into, and we'll move on from here because this starts to speak to the politics. If you don't have people in the workforce, you don't have people paying taxes. If you do things like what Biden just did with erasing $300 billion worth of student debt, somebody has to pay for that. College is not free. Regardless of what anybody tells you, it is not free. And erasing $300 billion of debt is a huge problem. It's going to put more strain on the system, and you're going to see higher tax raises for the low income and the middle class folks to be able to try to offset some of what's going on right now with this tomfoolery in Congress. But and it all comes back to healthcare because, folks, we rank number 11 in all first world countries when it comes to healthcare. Number 11. We're behind Canada, Australia, and the UK.
Yeah, it's a challenge. So you brought up a good point with the ACOs and Medicare Part C, and one of the big issues, the dirty secret is that to get you into a Part C or a Medicare Advantage plan, you typically are enrolled through a broker who represents a plan or multiple plans, and the brokers are paid commissions. And so, there's a whole bunch of guidance that CMS has put out regarding solicitation, and there's a whole bunch of guidance about what you can and can't do. I will tell you that what I hear from plans that work in this space, the plans, by the way, have to have an entirely separate unit or a group of people, because there's so much of it, that do nothing more than vet the complaints that come in to both CMS and the plans about people being switched without their consent or permission, and issues involving solicitation, because these brokers get paid so much money. If the push is on Medicare to put the bulk of the population into managed care and these MA plans, the problem is that burden of dealing with all of the potential horse trading and fraud is now going to be put onto the payers, which is going to result in higher premiums. Because we speak, where I am here to advise, we talk to plans all the time, and we know of one plan that they're dealing with thousands of complaints a month regarding this illegal switching, and now we're not even in open enrollment. Open enrollment is starting in October, November, and come January, when these people don't realize that they've been switched, come January when they realize, you're going to see this, it's thousands of complaints that are going to come in. So you got to be careful what you wish for, because by putting people into these plans, the cost, and I blogged about this the other day, this whole the medical loss ratio issue, that plans are supposed to have 80%, and in some larger plans it's 85%, is specifically to the delivery of care. So you can spend 15 to 20%. And so there are some plans, when you have that, they have to make payments back to the members, because they've collected more money and they've kept their medical loss ratios low. But what you're now going to have is the administrative burden that is put on as a result of this is going to be something that someone has to pay for, right? I mean, so you always got to be careful what you wish for on these things. So, I think this is a topic that we're going to continue to talk about. I think as we start to see what happens over the next few months and so with the Part D piece of the puzzle, and the negotiation, and all of the math that's going to come about as a result of that. I think we're gonna see that whether or not those negotiated prices really make a substantial difference, or are we talking about de minimis amounts that result in not really making a large change, I think is still out there. So I know, Sean, you want to talk about self audits a little bit more. I want to talk about them as always, because It is the hot topic. And I think at the end of the day, this all kind of comes back full circle. Providers are incessantly talking about how their reimbursements are flat. They're talking about, when you talk to and I have a little bit of this is theory, a little bit of this is from conversation, providers that are engaged in fraud versus the waste and abuse, but even maybe to some extent there, a lot of it comes down to, hey, look, the programs that I belong to are squeezing me. My reimbursements are flat. I haven't, I'm getting $50 for an E&M visit, this year. Next year it's $51. But all of my other costs continue to climb. I've got higher insurance costs. I've got higher overhead. My rent has gone up, right? So getting back to Jordan's point, it's not just an average of $1,800 for regular rent, but commercial rents are all going up. And so the question then really becomes, where do I look to scrimp for a dime to save a dollar? And so I think when we get to the self audits, and I say this all the time, you want to be the penny wise, pound foolish. You don't budget to do this work, but at the end of the day, doing these self audits are the things that help to create revenue preservation and revenue generation. And I know the three of us, talk about this I think I talk about it with you guys until I'm blue in the face. And I know you as well, Sean. The self audit thing is just something that nobody wants to get. I don't know what the social or business decision or what it is that's stopping this from happening, but it is mind-boggling to me the number of providers that are out there that aren't doing this or are doing it, just aren't doing it the right way.
So for me, I think it comes down to ignorance, plain and simple. For me, and I blogged about this the other day, like you, I'm very active with, writing articles and blog posts and things like that. And I did a blog piece for the National Alliance of Medical Auditing Specialists, NAMUS, right? And it was their audit tip of the week. And I talked about the critical importance of self audits. And I always go back to, at least in 2022, I go back to the case that you, Robert Lyles, and I, had to deal with on behalf of that, poor provider in a small town who, got caught up as part of an OIG study, and where CMS had sent out advisory notices, and they even got these notices, but they came after OIG had already said, we want double damages. And if you keep it up, we're going to ask for treble damages because we have that right under the civil monetary penalties law. For me, it comes down to one simple thing. You got to be smart, and you got to, you've got to be taking a proactive approach to your compliance, because you're never going to be able to convince an investigator. You're never going to be able to convince a prosecutor from the DOJ that you have a culture of compliance in your organization if you are not doing the most basic thing, which is self-auditing your documentation. If you're receiving remunerations for services that are, one level above what you should typically be getting, unless we're talking thousands of claims, more often than not, most payers aren't really excited about that, because we're talking about a tiny differential between a level 2 to a level 3 or a level 3 to a level 4, right? But if you're consistently 2 levels above, where you're billing a level 4 and you should be billing a level 2, and now you have a detectable pattern, right? Because you're an outlier or you have an aberrant coding pattern, you're going to be a target, and it's low hanging fruit. So,
That's right.
if I'm, so Eric says this all the time, and, I don't really ever, respond to it, for a lot of reasons, but Eric always says, you've done more courtroom testimony than anybody I know. And I was thinking about that today. And the truth is, I probably do. I've probably been a part of 50, civil or criminal federal cases. And it always comes down to, during those cases, for the ones that are able to prevail, talking about how they have that culture of compliance, how they've built that living, breathing document, and how the very first step in everything that these successful organizations do stems from the auditing and monitoring, not of the compliance program by itself, but of their documentation.
Yeah.
And I had this conversation today, Jordan. I'll pause in a minute, but I just got done having a phone call with a client, and they seem like the nicest people. And I can't call them a client because they're not a client yet. We were having this conversation through an attorney, and they seem like the nicest people, and they seem like they're really well educated and that they're really staying on top of this thing. But the whole conversation came up again about, if you knew that you were being reimbursed for something and you did nothing about it, well, if OIG knocks on your door and says, we want the money back, but we want double damages, you don't have any room to negotiate, because they're going to say you had that opportunity to self-audit and to either refund or self-disclose if you believe that rose to the level of fraud. So, Jordan, let me stop and go ahead.
No, I mean, I was going to say, I think I totally agree with you. And that's the problem, is I would like to think it's ignorance and not just gross negligence for people not doing it. But ultimately what they want to see is, it sounds good to say, yes, we have that culture. Their next question is going to be, what are you doing as an action, not just words, but an action to show that you're doing something to move forward. And we actually have, some of the simple stuff where it'll come by 9 months, 10 months, 12 months later, and we look at something. And even something as simple as like place of service. So your place of service determines, how much you're billed for certain codes like E&Ms. And, we accidentally put place of service 11, which is a freestanding office, for 12 or 13 months when it should have been 22 in an OPD hospital. And it's like, how does that happen? Because if somebody's doing the most basic level of auditing, so it's not like it just slipped once, right? It happened for 12 months. And nobody caught it and nobody's looking. But the most basic form of auditing catches that. I agree with you.
Such a great point. Go ahead, Eric.
But what I was going to say is that, a lot of it just comes down to an instance where the provider is unfamiliar with something, right? And so, I'm working on a project right now where the provider's claims had certain modifiers attached to them. And I went back to the provider and I said, why are you putting these modifiers on? These aren't proper modifiers. Or our billing company told us. I said, well, okay, but do you even know what this modifier is? No. And we'll get our billing company to write a letter saying that they told us to use it, and I said, that's all good and well. But at the end of the day, that claim doesn't have your billing company's name on it. The fact that you have no idea what that modifier is, you certainly know what that CPT code is, and you certainly know how much you're getting paid for that CPT code. How would you not take it to that next level? So, it's really, the job, the business of medicine is no longer the practice of medicine, and healthcare providers are much smarter than they were. They're much more savvy. They have medical degrees. They also have PhDs from Google and things of that sort. So people are out there doing this research. And it's like, you're missing this boat. If you just did a little bit of basic homework, when your billing company tells you to use a certain modifier, or your billing company says change this CPT code, the first thing that you should be asking is why? What is this modifier? And what is changing this modifier going to do? And why should I change it to this CPT code? If you're not going to ask those questions, at the end of the day, the person that has to write the check back is the provider. It's not the billing company. The fact of the matter is that if you have an overpayment and you have to make that overpayment, and your billing company received a portion of that money as a percentage on the accounts receivable, you're going to have to go back to your billing company and go, guess what? And maybe you have to sue your billing company. You have to file a civil suit to get the money back. If there's an overpayment, my favorite, you get an overpayment and you have to return money because the documentation wasn't supported by that code, and your billing company was doing the billing and looking at the coding and doing all of that. At the end of the day, you're out that money, but your billing company was still made whole, right? So that, where's this line that you draw? And it really is, the self-audit piece is something that I'm constantly perplexed by. And I think I've said this to you. I went to a potential client who claimed to be a mom and pop shop. They had 6 offices in 5 boroughs of New York. Some of the places were in buildings that they owned, and they were open 6 days a week, 12 hours a day. How are they a mom and pop shop is beyond me. And I jokingly said, unless you're taking chickens for healthcare, you're not a mom and pop shop, because this is a business that you're making money on. But they said, well, we didn't budget to do this work. We didn't budget for our legal defense. And I always go back and say, the only people I knew that budgeted for their legal defense, was John Gotti, right? Because if you're going to engage in the crime, and you're paying your lawyers to be kind of at the ready. And the thing about self audits that I think is the hugest misnomer is people think that it has an inordinate cost associated with it. To do a quarterly sampling, not even statistical, just a probe sample, but however you're going to do it, it is actually not that expensive. We all do them, so we know what it costs. It's not as expensive as providers think, and you get actionable intelligence on how you're going to go forward, right? And it's
That's
just,
right.
it's
I think the billing company deal, and Sean, I'll turn over to you just a quick comment, is the most misleading to me, because I hear what Eric hears all the time. My billing company said, that billing company is never going to trial. They're not working the OIG, the DOJ. They're not working any of these cases. The billing company is, believe me, their contracts are tightened up at the end. They got no liability. They're hands off, because at the end of the day, like you said, Eric, you submitted the claims. But again, they're not going to have the responsibility. But the billing company is what I often hear.
Well, let me just kind of put a dagger in that misnomer about, well, the billing company did it. Okay. So, and Eric, I know you love when I quote scripture, so I'm gonna get holy on us now. Okay.
Program Integrity Manual, Chapter 3.
No. I'm going to the codified. Okay. So I'm going to the United States Code, and I'm going to 31 subsections 3729 through 3733. And I know you guys know exactly what that is. It's the False Claims Act. And to Betty Hovey's point, because she raises a good one, okay, they are responsible, because the FCA clearly states any person, okay, who knowingly submits or causes false claims to be submitted to the government, or makes a false record or statement to get a claim paid by the government, is liable for up to triple the government's actual damages, plus a penalty for each claim. But here's what people don't understand is that, forget about the treble damages. There are actual damages that are also assessed. And what you have to recognize is that these actual damages are linked to the inflationary rate. Okay. And, committing a crime or having a civil action against you during a heightened level of inflation is not a good thing, because it ranges anywhere right now from $11,665 all the way up to $23,331. So
per instance.
Per occurrence. Per instance.
That's right. And people need to understand that the damages can far exceed what the loss amounts are, even on a single. And I think we've joked about this, that if you're going to commit fraud and you're going to be charged civilly, you're always better off doing that in times of low unemployment and low inflation, because you'll have to pay back less money in the aggregate. But that's actually an important point, is that the damages piece, people, I think, oftentimes fail to think about, that it's not just the penalties, rather. It's not just the double damages or the 1.5 times that you settle and things of that sort, but it's what that penalty multiplier is that can, in the aggregate, and you don't really see the penalties coming in to the level that the statute has. Oftentimes, double damages is usually the settlement agreement, and the government doesn't go after the penalties. But if you put the government to its task, meaning filing a civil complaint against you, or the OIG, filing a demand letter, they are going to go for the treble damages. Now, under the False Claims Act, it's treble damages of what was paid. Under the CMP, it's the odd carve out. It's treble billed, which is, as we know, not even an accurate number. But under CMP, it's treble of the amount claimed is what they call it, plus those penalties. And so if you're going to put the government to its task, they're going to look to get every ounce of blood out of that stone that they can possibly get.
Yeah, they're going to exact their pound of flesh. And
Right.
one other thing, Eric, that I wanted to finish out with, and then you and Jordan kind of finish out on the operational and law enforcement side. I feel compelled to talk about what it means to be a strict liability. Okay. Go ahead. Since you have the center square tonight on the Hollywood Squares, I'm going to, you take this one.
The strict liability thing is something that I think we talk. I think you and I and Jordan, but certainly you and I think probably every week or every other week, we're talking about strict liability. And the problem with strict liability is that whether you feel you were in the right or in the wrong, your documentation can be pristine. Every T crossed, every I dotted. Medical necessity does not come into play with respect to your documentation and strict liability. It is the policy says this, you went askew, that's it. If the policy says you can only bill for this service one time a year, calendar, rolling, whatever it is, and you do it twice, even though you may feel there's a medical necessity for it, and your clinical decision-making says this is what should be done for the patient, and it is within your plenary license from the state, and you can have 100 doctors stand up and say, this was a medically necessary procedure. If the policy that's out there, the NCD, the LCD, whatever it may be, says one time a year and you do it twice, that you have violated that policy and you're done. And there's no wiggle room. And we have learned that. Sean and I have learned that on the project that we worked on with Robert Lyles. We worked on that very hard to try to get the matter treated as an overpayment and not, as a double damages. But under the strict liability theory, your wiggle room is nothing. If it says do not pass go, do not collect $200, and you said, well, if I didn't pass go, I would have gotten hit by a car, I don't care about the $200. They'd say, guess what? We'll come visit you at the rehab center.
That's right. And I think the most important thing that came out of that meeting with OSIG was the statement by the attorney who said to us, it's not about medical necessity, guys, because our position is if it wasn't medically necessary, you wouldn't have billed it to Medicare in the first place. So medical necessity has nothing to do with this.
That's right.
This is a strict liability issue where we said under an LCD, and they agreed with it. There was no NCD, and they agreed with it. But they didn't like the argument, even though it was a great argument. And I think had we gone to federal court, we would have prevailed. But
right. Well,
who's gonna litigate $120,000 case?
So that's the problem. The problem is the price of doing business. Is it worth spending $150,000 in legal and consulting fees to win and have a moral victory, but be financially decimated because you've spent $150,000 plus you run the risk of losing? And if you lose, that 120 or 140 or whatever that number is trebled, and before you know
it's compounded.
It's $1 million. It's $1 million. So yeah. So in the last 2 or 3 minutes, I want a quick wrap up. There was a case that was recently put out, a press release on a case involving a doctor. I'm just reading from my notes. Armando Valdez, $35 million in claims were billed, $8 million paid for infusions of Remicade that never occurred. And I believe, if I recall correctly from the presser, it went on for a decade. So 10 years worth of billing for Remicade. Now, I didn't do enough research to identify what kind of doctor he was. Is he an endocrinologist in medicine? But, for those of you that are watching, Remicade is a Part B as in boy reimbursed drug. It has a reimbursement rate that could be as high as $10,000 per instance. There are a number of equivalents that do not require it to be infused in the doctor's office under the Part B benefit. There's some drugs that would fall under Part D that are its biologic equivalent. I had a case involving something very similar many years ago when the drug first came out. Doctors were not real hype on wanting to set up infusion suites in their office because there is an inordinate cost to doing that. You've got to have an infusion suite. You need the equipment. You have to have tables and chairs for people to sit on and TVs for them to watch and that. And so there were all kinds of things like preceptorships and all kinds of ways to get around it. But, the thing about this, and I'd love to know over the period of time that people were purportedly getting it, but they weren't, did they not have a diagnosis? It's typically done for people with rheumatoid arthritis, and it's got a secondary gastrointestinal for Crohn's disease. I don't know if this doctor was an endocrinologist, a GP, or a gastro, but the point is, did these people have a diagnosis that required or potentially was for Remicade previously? And then the next question, which comes into the data piece, is how long were they getting this? Because this isn't a drug you get it like a one and done. It's kind of a maintenance drug. It just surprises me yet again that a 10-year period of time went forward, before this was discovered, and more importantly, that we're continuing to pay for drugs in this environment when there are these other equivalents, and that somebody isn't scrutinizing, like, why is there a $10,000 cost associated with it? Jordan, you do a lot of this with pre-authorizations in the radiation oncology space. Is there even room in something like the Medicare program for a pre-authorization that exists in parallel in the commercial space?
So no, there is. And I think to your point with this drug, and I want to talk about this on the next episode we do, but you're about to see a wave of what we call biosimilar drugs. So basically it has the same efficacy, it's a different formula, but the drugs are cheaper. And for this reason, when we start looking at these drugs that have had the golden road for years and years and years, it's been one pathway, they've had the patent, you're going to see this biosimilar space, and biosimilars still will require authorization, but a lot of these payers, especially commercial payers, are adopting that you utilize those drugs first before you go to what we would consider the brand name or the fully established, because the biosimilars efficacy is still there. So the prior auth for these drugs in this space is for rheumatology, for infusion, specialty pharmacy drugs, oral oncolytics, infusion drugs, is almost 100% now, everything that we're seeing. And so the gatekeeping mechanism there is astronomical, all the way down to if you've still got the same drug like iron. If you're getting injections of Venifer or something of iron, that they won't cover that, but they'll cover another one that's cheaper. And they are pulling the trigger and holding the levers of which ones you can use now.
Right. All right. So, fellas, it's been, as always, another spectacular hour. We actually went a couple of minutes over.
Hey, man.
I would say it's
here's my question. When are we going to see the three of us on the front of compliance today? That's what I want. When are you going to see the Chuckleheads, the original CCC, on the cover of compliance today?
That's that special.
Not taking anything away from Donata Horseman, who I know, who is phenomenal. She is awesome. But when are we gonna get our mugs on here? That's what I want to know.
Hopefully soon. You never know. You never know.
We'll be on that back page.
On the back page.
I don't think we'll ever be on back page. Let's get that squared away. All right, guys. Listen, we're out of time. Another scintillating episode. It's just each time we get going, I really feel like, are we going to make it for an hour? Do we have enough to talk about? And we really have more than enough to talk about. The healthcare fraud, waste, abuse, compliance space, data analytics, compliance, the law enforcement part. I mean, we could do this and just go on. So, as always, it's been a great hour spending it with you two guys. I love you both very much. You're great friends professionally and personally. For all those that tune in, really enjoy having you for the hour. The comments that everybody was making today were great. We enjoy having you on with us. We enjoy you joining us. And in the words of Sean Weiss, be good to yourself, but be
But
good
more
to each other.
importantly, yeah, that's right.
Yeah,
you
more
hear me?
importantly, be good to each
We're,
other.
we're learning, man. So thank you.
But I do want to say one thing, Jason Zemek, thank you so much for hanging out with us today, brother. We appreciate your service as a former Iraq and Afghanistan vet. Your service is greatly appreciated. We salute you. And to each and every single one of you, thanks for tuning in. Thanks for hanging out. And thanks for logging on for just a little while with the Chuckleheads. Until next time, be good to yourself, but more importantly, be good to each other.